Wow.
Good evening, everyone, and welcome to today's Pan India ILD MDM. We have five challenging cases lined up, three by me, one by Vinod from Chennai, and one by Rajan sir. Each case brings unique dilemmas and diagnosis in management. And we are truly privileged to have exceptional panel with us of Professor Athol Wells, sharing his wisdom as usual, and pulmonology experts Murli Mohan sir, Prahlad Prabhu Desai sir, and Rajan sir. Dr. Vimal Raj as our radiologist expert and Dr. Sharda is pathologist. Thank you so much for joining. And we have got geneticist Dr. Dhanya and Dr. Pooja for a special case, which we might have a genetic knowledge required. So thank you so much for joining Dhanya and Pooja also. So let us begin with the first case, and I will start sharing my screen. So I have put the first case is slightly, for me, it was more complicated than usual. She is a 47 years old lady from Kollam. Uh, I'm sorry, I forgot to. Mithun, are you there? Hello? I need Mithun also, but I think he will be joining. So 47 years old lady from Kollam who is a staff nurse, and he came she's a non-case of systemic sclerosis, sign scleroderma. She also has coronary artery disease and post PTCA in 2022. She's diagnosed with pulmonary arterial hypertension. She is having type 2 diabetes, systemic hypertension, which was diagnosed at the time of pregnancy, hypothyroidism, and esophagitis. She came to ER with worsening difficulty, breathing difficulty, cough, most probably infection and fever. When she came to ER, her saturation was 60% on room air, which went to 91% on 5 liter, and heart rate was 72 per minute. We have to admit her in ICU, and she has BNP of around 2000, 3000, not very high, borderline BNP. These are the previous tests which were done. She is a follow-up of Dr. Mithun. She was diagnosed as ANA-IF4 plus centromere pattern, and rheumatoid factor was also positive, but it was a sign scleroderma which was diagnosed. And that time, I believe her CT scan was normal. This time she came with increased breathing difficulty, and CT scan, I think Vimal Raj sir will be sharing very soon. Other than her hypoxia and her BNP, everything was okay. These are the previous investigation which were done by Mithun. If you can just quick comment, Mithun, from you, what was your diagnosis when you diagnosed? You muted, Mithun.
She had pulmonary artery hypertension, and when you have pulmonary artery hypertension with a anti-centromere antibody positivity, you have to consider it as a sign scleroderma because pH limited scleroderma with pH, and RAW52 can be associated with these antibodies. And at that time, there was no evidence of ILD. There was no myositis also. This is pure pH with
Yeah,
anti-centromere positivity. No skin lesions.
sure. I think I will stop sharing, and Vimal Raj sir, please show the images.
As Vimal pulls out the images, Mithun, centromere antibodies are usually associated with a better prognosis, right?
Sir, that depends upon the organ involvement. When there is an anti-centromere antibody, there's a chance of pulmonary artery hypertension. If you get a pulmonary hypertension, then prognosis is not good.
Got it.
Otherwise, for skin aspect, it is good. And ILD aspect also, it is good.
Yeah, that's what okay.
So this is a CT scan. So we have two CT scans. One is 3 years old from November 2022, and one more recent from September 2025. So this is the older scan from November, where we can see that the pulmonary artery is a bit dilated. The RA and the RV are also dilated, and the interventricular septum is also straightened. All of this pointing towards underlying pulmonary hypertension. At this point in time, when we look at her lungs, and there is not much to see in her lungs at that point in time. There's pretty much normalish lungs with nothing going on in 2022. Fast forward to now. Now this is September 2025. And when we look at the mediastinal window, there are small volume lymph nodes. There's some prominent along the aortopulmonary window. You can see in the mediastinum in the subcarina. And then there is this larger lymph node, which is there in the right subcarinal region going into the lung. You can also see perhaps small amount of pleural effusion here, trace pleural effusion, which has started to come in that we are looking at, and some pleural reaction in the left lung base also, which was not present previously. Now, there is some, if you see, this is the adrenal gland here. There is some non-specific inflammatory changes and around the adrenal gland. This usually is seen in people as an acute stress response. People who have hypovolemia, you can see some similar changes. So focusing on the lung parenchyma, this time around, the lung parenchyma looks grossly abnormal. And what we are seeing here, you're starting to see some interlobular septal thickening, and then these diffuse areas of bronchocentric brown glass nodular infiltrates, which are there in the lungs bilaterally. You can see some areas of confluence of these ground glass areas, upper lobes, and as we come down into the lower lobes as well, with smooth interlobular septal thickening again in the lower lobes that we can see. And there's no cystic change, there's no honeycombing. If we look at the expiratory scan at the same time, not much. So this is the tried expiratory scan, not much in terms of air trapping that can be seen in this case. So between a period of 3 years where the lungs were almost normal to now, we are seeing bronchocentric ground glass changes, interlobular septal thickening, trace bilateral pleural effusions. In a acute presentation, the first thing would be a viral pneumonia, would be something that we would consider, especially those pleural effusions fit in with that. There's some lymph nodes also. The other thing is an acute hypersensitivity reaction of some sort that one would look at in this case. And the last one would consider it's a manifestation of an NSIP pattern, an early NSIP pattern that we would look at here.
Okay. So we we thought the pleural effusion was part of the cardiac failure, right heart failure, which she was having, and I didn't bother to touch the effusion part. But once she was stable, even though it was risky, we went ahead and did bronchoscopy because one of the reason she didn't give any history of exposure, so HP was uh, very unlikely fitting into history, and infection was also possibility. So we did bronchoscopy and lavage. I didn't have guts to do biopsy considering her hypoxia, and everything could have, like, bleeding could have happened, and also only bowel was taken, and that was not conclusive for anything. Everything came negative. This is her spirometry function, pulmonary function test, which was taken 2 or 3 years apart. The latest one which was available was only October 24. That time she desaturated from 95 to 60%. So she started with 97 to 83, which was holding on in 2023, but became 60%. So since October 24, she has started worsening, and her latest echo, which was done in September, was showing severe pulmonary hypertension with RVSP of 40 plus RAP. And this time, when we admitted, that time itself, she was on maximum medicines for pulmonary hypertension. She is on endoblock, she is on selexipag, and she is on other cardiac failure medicines. With from Mithun side, he is treating with Folitrax and Folimac. My problem with this patient was she was hypoxic, and the pattern which is there on the CT scan is actually like steroid responsive. And even though the diagnosis was systemic sclerosis, I had to give her solimedrol 40 milligram. at the time of admission, which I have discharged on 20 milligrams. So the reason for discussing this case is, even though there is a rule that in systemic sclerosis more than 15 milligram is contraindicated, what do you do in such pattern? And now the diagnosis, CT scan, the newer classification has come as a bronchocentric pattern. So isn't this a bronchocentric pattern, sir? Vimalraj sir? This is a
It is a
bronchos.
bronchocentric.
Yeah.
Yeah,
So
absolutely.
bronchocentric pattern, only 3: infection, hypersensitivity, or OP-like manifestation. All 3 will respond to steroids. So was the decision to initiate steroid justified despite the non-risk factor of scleroderma renal crisis? And how should ongoing management be balanced between antifibrotic? Like, I know this is not fibrosis, right, sir? This is
No,
something reversible, right?
that's correct.
So yeah. So we that is the main reason I put this case for discussion. Yeah.
So it's not an absolute contraindication, Asmita. There's just caution that has been advised with steroids and renal crisis, as far as I know. The other thing is, all this treatment has begun since a month. You're saying there was no pH therapies going on before this?
No. She was already on these medicines. We
Which one?
just everything,
You showed
Selexi
them
peg. Yeah.
slides from, because you have just put
No,
those
no,
links on that as recently started, or
no. This is not. This is Lasix and Lasilecton was recently added. The diuretics are the only thing which we added recently, because my cardiologist felt that it will be required now.
no. So
Uh,
nintedanib 1 month, steroids recent.
yeah.
Your-
Everything else he was
everything that's
already on, except the
methotrexate,
yeah.
Bosint, the ETRA, Selexipag, and there's no PDE5 inhibitor going on?
No, only this. Yeah.
The endoblock is ambrisentan plus
Tadalafil
Endoblock
combination.
T, sorry,
Yeah,
endoblock
endoblock.
T.
Yeah,
Okay.
endoblock T.
So you have triple. So this is going on since how long?
For last 6 months, more than 6 months, sir. She's on
more than
Mex.
6, I think 1 or 2 years.
Yeah,
Because she was diagnosed with significant pulmonary
pulmonary
hypertension.
hypertension. Yeah.
No right heart cath was done that time, right? A diagnosis.
No, sir, we didn't do.
She was treated based on the echo, and she's on
Yeah.
triple drug for that. Plus, she's on methotrexate as a
Methotrexate was initiated for joint pains.
for the joint pains, right? Yeah. So,
Smita,
yeah.
this doesn't look like why patients should have on methotrexate, etc., and acute hypersensitivity pneumonia to develop. It's an infection. Probably have you done PCP, etc., CMB, and all those things?
PCP, I just sent cytology, sir. We don't have
No,
like
PCR studies.
special.
No.
No, we didn't send anything.
And pneumocystis carinii is quite possible in this patient on methotrexate and developing such a permanent central lobular nodules.
Yeah.
Dr. Vimalraj, I'm just wondering actually whether this pattern, whether it could be due to mosaic perfusion due to the pulmonary hypertension itself. What do you think?
No,
Perfusion defects.
no, these are
These-
not. So what you're seeing with mosaic perfusion, what you'll have is areas of bright and areas of dark. These are actually, and they are segmental. These are bronchocentric, non-segmental. This is not mosaic perfusion. This is not pH related.
All right, okay.
If somebody first time presents this with pH, we
Yeah.
think of an entity called as PCH, pulmonary capillary hemangiomatosis, which can have these ground glass changes. But initially it was all normal, so that's also not considered.
All right, okay, thank you.
But this pattern doesn't match with PCP, na, sir?
It can.
It can,
Okay,
because you've
okay.
got bronchocentric, ground glass,
Classic way.
bilateral.
Yeah.
You
Okay.
definitely can.
Okay.
But she was not
So-
on any immunomodulation except for methotrexate, right?
No, she was not on any other medications.
Nothing else. She was not on steroids. So this all was
No.
happened after only on methotrexate. The steroids were introduced after this happened, right, Asmita?
I introduced steroid when she was in ICU.
Correct.
And I saw the CT in this pattern, and then after taking lavage, I started her on. We waited for BAL to immediate come negative, and then started.
You want to summarize that in 2 minutes for Athol since he's joined?
Yeah, I want Vimalraj sir to show the CT scan first, and then maybe this is a known case. Yeah, sir.
There's email connection problems. Sorry about that, but I'm here now. Mighty fast, and I'll comment mighty fast.
So,
one of the other, Dr. Asmita, I'd like you to do is a CMB quantitative.
CMB, yeah. Okay. I can do that. Yes, sir.
Yeah.
So this is a 47-year-old female. She's had a CT scan in 2022, which was absolutely normal. This is the current scan where we are seeing inspiratory and expiratory images, where we're seeing these bronchocentric ground glass nodular changes with some large areas of confluence. There is intermittent areas of interlobular septal thickening, very trivial pleural reactions bilaterally that we can see, and some subsegmental atelectasis in the left lung base.
History leading up to the scan in just 2 sentences, very quick or insidious. Hello?
Sorry, at all, missed that.
Symptoms leading up to the scan, very quick or
Acute breathlessness,
I will
severe
say.
desaturation coming to the ICU, right, Asmita?
Yeah. So
And we
she's
had a
a
CT
known case
scan.
of systemic sclerosis diagnosed somewhere in 2022, presented to ER with saturation of 60%, and this was her connective tissue disease profile when she came. At the time of diagnosis, she is on methotrexate as a treatment. This is her spirometry. Severe pulmonary hypertension was on treatment for the same. This time it is fever, cough, and increased dyspnea. Her baseline saturation was around 88, which became 60% on RUMAT. So she came to ER, was diagnosed as acute exacerbation of interstitial lung disease. And the CT scan, which was normal in 2022, was showing centrilobular pattern. And after doing bronchoscopy and lavage, we started her on Solumedrol 40 milligram. The questions were, in systemic sclerosis, whether steroids can be justified, and what is this pattern? Is it infection? Is it systemic sclerosis related interstitial lung disease, which is happening now, or anything else?
I don't like acute exacerbations as a term in this setting because people transplant IPF acute exacerbations into a complex scenario. I think a form of infection is completely and utterly on the cards, and you have to chase less usual infection here. With this rapid onset, and I would guess from the baseline FVC, there isn't severe ILD. Maybe there is, but you've got a vasculopathic profile. So I don't see how you get to have a UIP like acute exacerbation. And if you did, it wouldn't look like that on this scan. I don't see that there's separate ILD mixed in with what you're seeing on the scan. So I don't think acute exacerbation helps as a term. So this could be a weird autoimmune flare, but you'd need to say she had lupus overlap and go along the lines of it's not really scleroderma in the way it's behaving if it's autoimmune. And I wouldn't discount that. I mean, no doubt you have looked at lupus overlap. I've missed a lot of the results, so I'll leave that. But if it isn't that, and it's not a drug side effect, and it could be a drug side effect, and I guess methotrexate is discredited for fibrosis, but you can get an acute pneumonitis very rarely with methotrexate. To me, it's probably too diffuse. And if it really is a drug side effect, you're looking on a pathway to diffuse lung injury. And then otherwise, infection, I think, would be top of a list. And I don't know, you've got to grope for really weird things otherwise, I think. Did anyone else have a major differential to what I've just said?
No.
We were talking about viral infection, PJT.
Yes, I am. Yeah, very much so.
That's what we were
Very
also.
much so. I've even seen, you will laugh at me, and maybe it's just a weird thing outside a TB endemic area. I've even seen underlying TB treated with immunosuppression get this sort of very widespread diffuse lung injury like look. But on the other hand, there's a look about this. You wondered about inhaled transmission. I'm grasping at the scan, and you need to look at it with. I'd want a radiologist to comment on this, but is there a sense of a little bit of nodular change in there of the sort that you might see with airway transmission of an infection? Or obviously it could be an underlying thing. You've obviously excluded PCP. I'm sure you've excluded CMV, and I've seen CMV in this setting, looking at something like this.
And further, Prof. Wells, actually, I mean, this question is on methotrexate, even though, it's very rare. Could it be due to methotrexate induce HP because it's a BIH type pattern? What do you think?
Well, yes, I mentioned methotrexate. I don't like HP for a drug. I'm not sure why people use the HP term for a drug effect. It's been traditional, I understand that. You are talking about a drug-induced pneumonitis. I'm not sure there's true HP pathways in that, but you're right that it can look like HP, for sure. Usually the drug doesn't go with an airway element, unlike HP in general. There are data to show that. So, and this case could be an HP mimic driven by methotrexate. In my experience, looking at the literature, more often methotrexate gives you more discrete, aggressive, inflammatory pneumonitis with consolidation. Can I rule this out as a weird side effect? No, because whatever this is unusual. So you can't rule out an unusual explanation just because it's unusual. So we would say perhaps the drug is playing a role without putting a term on that, and you'd stop the drug.
Thank you.
Because the mistake here that would really end her days is that it really is a drug pathway and you don't stop the drug. Even though that might be very unlikely, I don't see what option there is.
Yeah, I didn't check CMV. So if CMV comes positive, and then we do not have to stop methotrexate, right, sir?
And also
Well,
further, we can do serum beta glycan as well. And if it is positive, that is more likely PCP, isn't it? I mean,
well,
is it
I think
available?
the first thing to say, if it's CMV, I'm worried about the immunosuppression.
Okay.
And I'm not imagining the methotrexate is needed for the lungs. I can't quite believe it's going to help the pulmonary hypertension. I imagine it must be being used for systemic reasons. And I would say having a holiday from more immunosuppression would be a good idea if you find an infection. The trouble is, there's only two managements here. One of them's to increase immunosuppression, the other's to reduce immunosuppression because it's an infection. And I wouldn't go reducing or removing the methotrexate for that reason. I would be saying it might be responsible as a drug. So I reckon you've got to stop the methotrexate for that reason.
Okay.
I'm not sure why the methotrexate's being used, and maybe there's a systemic reason that you've got to replace methotrexate with something else. And if this is really a drug reaction, then you stop the drug, but you use other forms of immunosuppression, don't you?
Yep.
So that
Asmita, still, since the lavage is already done, you still can depend upon the tests like beta-D glucan levels and CMB, PCR in blood to find out the possibility of PCP CMB.
Yeah, CMV PCR I'll send. Beta-D glucon is not
Beta-D glucan is
available.
very useful
Yeah.
test for the PCP.
Yeah, but it's not available in my hospital. And
Okay.
let me see if I can send it outside somewhere. Anyway, thank you.
What
I
is
will.
LDH levels? Very high or little high?
No, it was 190 kind of, not very high, sir. Okay.
So there is some evidence that using an anti-inflammatory medication in CTD associated pulmonary hypertension does help. But you've got to take a call on, sorry.
Did the patient get better with steroid, Asmita?
She improved. Yeah,
Yeah.
I discharged her with actually at the time of discharge, her oxygen requirement was hardly 1 liter, 0.5 liter. Even off oxygen also she was fine. Predominantly she improved with non-invasive ventilator and oxygen, both.
And
with the treatment.
steroids.
Yeah, with the treatment,
Yeah.
with the steroids and whatever antibiotics we gave. BAL came negative, expert is negative. I'll follow up the cultures. PCP in cytology, it didn't come. Biofire, I didn't send. And CMV, I will send.
So, Athol, in light of that, antibiotics, systemic steroids, oxygen, it's likely the steroid help, right?
Well, all I can say is, how do you mess this up? And one way is that it's methotrexate driving it.
Right.
So I'm worried about continuing methotrexate, even though I agree that it's unlikely. That's the way in which, in the end, there's a bad outcome. And other than that, you've got an improvement with steroid therapy. That could improve a methotrexate reaction while you're still using methotrexate. I think you've got to be very critical about the methotrexate, and you've got to search harder for an infective trigger, because you could dampen down the immune response to an infection, as often is in PCP initially, and then have a bad outcome in the longer term. So doing it in steps, I'd stop the methotrexate, work out why it was ever being used, decide whether you need an alternative drug to methotrexate, which might help, by the way, if there really is an immunological pathway to what's going on in the lungs. So you probably can't pull out the methotrexate and not replace it, I think. And then the trick is to nail an infection if you can. Now, if she goes on getting better, as time passes, you're less and less worried about infection, aren't you? And you can start to breathe more easily. But I've seen this sort of honeymoon period with infection where you think you're treating an autoimmune process, but it really was infection driving it. I saw it twice with CMV in inflammatory myopathy, where for all the world you would not have felt after the initial response that infection underneath was driving it. So time, the gift of time, and increasingly reassured as she goes on getting better.
Okay, I'll do that, sir. Thank you. Next, moving on to next case, who is a 62 years old man. He has recurrent infection. He's a reformed smoker. He told he used to smoke almost 2 packets per day cigarettes for last 25 years, and he stopped only for last 8 years. Presented with fever once again, cough, breathing difficulty, and some some non-specific complaint. Saturation 96, bilateral V is present. This is his ANA profile. RF factor was 10, which is positive as per our report. Anti-CCP negative, ANA negative, ESR 85, CRP 48. Other investigations except hemoglobin were normal. ANA profile, Mithun, negative, right? Nothing significant.
Yes.
Yeah, and we found excessive dynamic airway collapse. Other than that, nothing in the bronchoscopy. Lavage was taken. This is his spirometry across last 8 years. From 47.5 FVC, it is 48% now. FEV1 34, around 31 now. And ratio of 75 to 53. DLCO, only this time he could do, which was 24% of predicted, KCO of 30. He desaturated from 98 to 92%, and 360 meters he walked. That was almost similar, except he used to walk little bit more in last 2 6-minute walk tests. No pulmonary hypertension and echo. And with that, I will stop sharing.
Okay, so this is the 64-year-old gentleman. We've got 2 CT scans for him. I'm showing you the most recent one to begin with first. This is from September 2025. What you can see in this guy is like the trachea is quite prominent. Not seeing it collapse, but it definitely is very prominent. There are some atherosclerotic changes in the aorta and then small volume mediastinal lymph nodes, not really significant. And when we look at his lung parenchyma, I'll just go to the top. What you can see in the lung parenchyma here is that there is paraseptal emphysema starting at the real top. There's some focal areas of pleural thickening. minor fibrotic changes, lots of emphysemas going into centrilobular emphysema. And then there are some intervening areas. I'll just zoom it in. And then there's some intervening areas which give an appearance of maybe a cyst, but predominantly these are emphysematous changes that we are seeing. As I come down into the lungs, what we are able to see here in the left lower lobe are some diffuse area of ground glass opacity, patchy atelectasis here. You can see peripheral ground glass, and then the bronchi are slightly prominent with some bronchial wall thickening. All these have some inflammatory changes here in the left lower lobe. Otherwise, the lung looks okay elsewhere. So a lot of background of emphysema and some inflammatory changes in the left lower lobe. We do have a companion scan for him. This scan on the left-hand side is from February 2024. And if we go up, you can see that the left lung at that time was almost normal, left lower lobe especially. And the emphysematous changes were there even at that time. Lot of it bronchocentric, paraseptal as well that we are seeing. So to me, this looks more of a emphysema, few cysts here and there maybe, but not a cystic lung disease. Emphysema with some areas of acute inflammatory process in the left lower lobe, most likely infection.
Okay, yeah. I think that was the only doubt, that whether does this represent cystic ILD or CPFE? Like, I'm not telling CPFE, but emphysema, there is no fibrosis as such, right, sir?
Yeah.
There is only infection, and we just treated him as a COPD as of now, and I think I'll continue doing that. Maybe anything anybody wants to add, we can listen.
No, completely agree.
I don't know why I'm getting muted by somebody else, actually.
I did it because there was some voice coming, sir. That's why. Okay.
Okay, lung function is classic for emphysema and not changing in the long term. KCO, DLCO, airflow obstruction, the sort of FVC reduction you get because of gas trapping. So it's classic for that. I like infection, obviously. Aspiration, because it's in the lower lobe and it's focal, and you can't rule out aspiration there. I don't believe you can say there's an ILD. And the only other thing is the cystic change. Very commonly, isn't it, if you look hard at smoking-related emphysema, you will find a few focal areas where perhaps there was a touch of Langerhans reaction, and you will find this or that better formed cyst. And the mistake is to go chasing Langerhans, I think. Some emphysema looks like it was Langerhans evolving to emphysema, but it is emphysema. It's that sort of pseudocystic look that you can get. But a touch of that in a patient with emphysema, I think we should resolutely refuse to talk about Langerhans in that setting.
Vimal, such a large trachea, does it anything it contribute to it in our diagnosis or in anything?
So you can get tracheobronchomegaly as age progresses, and we've seen in some of the Mounier-Kuhns and others tend to have that, but they tend to have some crypts, etc., which is associated with this. So in here, I'm not seeing any of that. I'm just seeing tracheobronchomegaly.
If that was the case, you could still say the lung function isn't changing over 8 years. And that, I think, would, I take it there was former smoking, and this patient is not smoking now?
Yeah.
Okay. So there's no reason to go chasing an alternative active process to emphysema, I don't think.
Smita, we can't hear you. You may be muted.
Asmeet has been muting people again.
Can you hear me now?
Yes.
Yeah, okay. Thank you. So 60 years old lady from Changnasheri who came with type 2 diabetes, systemic hypertension, hypothyroidism, multiple admission after 2021. She had COVID in 2021. After that, multiple admissions, chest pain and breathing difficulty. She came to me with dry cough for 3 to 4 months and dyspnea, which was MMRC grade 3, now became grade 4. And chest pain on and off for last 4 years. Loss of appetite present, no loss of weight. Saturation on room air was 97 and chest examination bilateral crepitation. This was her ANA profile. Mithun, do you think this is significant?
No, nucleus of 1+ not significant.
Yeah, RF factor was positive 40. I'm not sure whether I did NT-CCP. I have not written, mostly not done. ANA was 1+, ACE level was negative, creatinine was normal. Everything else was normal, yeah. And myositis profile was negative. She could not do PFT or DLC or anything. 99% was her baseline saturation, went to 90%, and she could walk only 120 meters. And we will just see the CT image and then I will put the questions.
So this is the CT scan for this 58-year-old female. And what we can see here at the top is that there are small volume mediastinal lymph nodes, numerous small volume lymph nodes. The pulmonary artery is not dilated. Again, this one is a little bit more than small. It's quite prominent hilar and subcarinal lymph node across here. Axilla also has few small lymph nodes. Very non-specific finding. Patulous distal esophagus, small hiatus hernia, and diffuse fatty infiltration of the liver, that we can see. And when we look at the lung parenchyma, we are seeing extensive areas of, you can start to see fibrosis, subpleural interstitial changes, traction dilatation of bronchi, some areas of architectural distortion, you can start to see here, and predominantly peripheral in nature. There are some superadded areas of ground glass. Beyond this, I think she's also struggled to hold her breath much. You can see large diffuse areas of bronchocentric ground glass going all the way out to the periphery. And around here, you start to see a lot of breathing artifact and patchy areas of air trapping that we can see across here, mosaicism, and extreme lung bases are relatively spared. There is no nodules or mass lesion. The fissures are slightly irregular, but not that of a fissural nodularity pattern. So what we are dealing with here is a fibrotic process. We've already started to see a lot of fibrosis, which has got both bronchocentric and peripheral involvement with acute inflammatory phase as well as a background of fibrosis. This is a fibrotic ILD process. This is not UIP. I'm thinking more in terms of with the RA factor being there, whether it's part of an CTD associated ILD that we are looking at. Asmita, you've gone mute again.
So I was thinking also that whether it is also RA-ILD related or CTD-ILD overlap. Post-COVID fibrosis. Do you think this looks like post-COVID fibrosis, sir?
I don't think so. No.
No. Okay. And any other differentials? And what should be the like optimal treatment strategy? I think I started her on Nintedanibia, 100 milligram BD. That is only thing which I have started. Nothing else, no other immunosuppressants I have added. Should I add if the panel thinks that this is more likely of CTD ILD, should we add something else or only nintedanib is enough? That is the question.
We can do a anti-CCP, no? We can.
Yeah, we can do anti-CCP. I didn't do that. Yeah.
ESR is also on the higher side, 85.
ESR is on the higher side. Yeah.
I think it's a fibrotic ILD. The right lower loop looks probably there may be infection. Esophagus is little dilated, maybe aspiration. I think we should try to find out the right lower lobe area, whether there's an infection.
Mithun, excuse me, I mean, I'm just wondering if you have anti-CCP versus anti-MCV antibodies, what is the more sensitive and specific?
Which one? Anti-CCP versus?
Anti-MCV.
Is it commercially available?
It's available. Yeah, it's available in the UK actually. We are using quite a lot of MCV. I mean, I can't remember I'll just tell you the
Anti-CARP antibodies are there, and RA33 MCV full form. I'm not aware.
All right. Okay. Thank you.
And she's not been on any treatment, Asmita, all this time. It's the first time presenting to pulmonology.
We know this there, no? I think, or you want to present, sir?
Would you mind going back to the first slide, because I lost vision, and I do potentially want to ask you one or two things. I was keeping quiet in the hope that other people would comment. You know, when you lose vision, you lose a feel for the case.
Which patient? Which case, sir?
One we've just been discussing.
Okay.
Number 3, right?
Yeah.
I just want to get a sense of the very start of this. So you've got breathlessness, and each time you're getting acute admissions, right?
Yes, increased.
And do these things go away completely, or have you got insidious chronic progression in the background?
Not very serious. She's still maintaining 97 on room air.
Yeah, but what I'm really asking is the symptom profile.
Yeah, very bad. Very bad. She's feeling very bad.
Gradually worsening over the years in the background.
Hmm.
And nobody's labeled an ILD before now.
Since 2021, she developed post-COVID pneumonia. After that, everything started worsening.
Look, I understand this is not classical acute COVID pneumonitis looking like that in all the series, and you get the slow regression and all of that. I would question, however, a subgroup of patients who develop immune dysregulation in some way triggered by COVID. And this will often happen and start, at least in our practice, and at least in the European version at least, sometimes 1 to 2 months after COVID, when COVID seems to have settled, sometimes with mild COVID. And those things can have a number of types, and I don't think we understand them completely. And they go with fatigue and brain fog. So I would not discount that COVID in some way set off an immune dysregulation. And then if it did, I don't think you could rely on classic autoantibodies to be able to see that. So I've taken aboard there's some scar tissue in the background. It sounds like it might have been worse, and then you're getting acute exacerbations. Now, whether those are infection on top of a process, or whether in some way you're getting a flare of autoimmunity, which we don't understand, I'm not sure. So what we're dealing with, I'm incredibly insecure at the end of all of this. And I think you'll obviously want, when the acute episode is settled and she can breathe properly, to repeat the scan and characterize what is there underneath. And then I think that there might be a better sense of what the chronic.
Okay. I'll do that. Sorry, I missed you, sir. You want to present, or should I ask Vinod to present?
Sorry,
Rajan, you
sorry.
want you want to close them?
Hear what I was saying then. Hello?
Yeah, Tom. Sorry, we can hear you.
Oh, that's good. I finished.
Yeah.
Just trying to weave what this was underneath, that was all.
Sure. Vinod, I think you go on.
Yes, ma'am. Can you hear me, ma'am?
Yeah,
Yes.
I can hear you.
Yes. So this female was referred from cardiology department, ma'am. She presented to cardiology department with the 48 years old female, no comorbidities, had giddiness on and off 2 months, had very bad event, dyspnea, palpitation, giddiness, and sweating on one fine day, and then she landed up in another hospital. Next slide, ma'am. In that hospital, they did an ECG, was doubtful MI, there was a heart block, was resuscitated. Then the repeat ECG showed again very a clear picture of an MI, ongoing MI, and then they thrombolized the patient, with injection tenecteplase. Then the patient was referred to our cardiology department. So where the patient was started on dual antiplatelets, statins, heparin, Lasix infusion, was supposedly on pulmonary edema. So meanwhile, investigation showed anemia. There was metabolic acidosis. She was on inotropes when she came in, which was gradually weaned off. In cardiac ICU, there was minimal liver dysfunction. ANA was worked up negative. ACE was normal. This after evaluating for cardiology, they retrospectively they worked up this ANA and ACE levels, ma'am. Otherwise, iron study showed iron deficiency anemia and A1C and lipid profile, other cardiac evaluation is normal. Next slide. So in the ICU course, after the initial stabilization, again, the patient had bradycardia, hypotension. Then at that time, they had to do an emergency pacemaker. After the pacemaker, the patient was an NIV and then decongested also. Then they further did the cardiac evaluation. After this pacemaker placement, next slide. Then they did coronary angiogram just to see the coronaries were normal. There was sluggish flow. And then 24-hour Holter showed intermittent left bundle branch block. There was AV dissociation. Echo showed hypokinesia. Cardiac markers were minimally elevated. ECG showed still AV conduction and prolonged PR interval, the changes. So they went ahead and did PET-CT for further evaluation. Simultaneously, after the PET-CT initial verbal report, they had evaluated for the ANA autoimmune workup and sarcoidosis.
You want CT?
Yes, ma'am.
Okay.
So this is the PET-CT component of the CT PET scan, and what we can see when we start from the top in the mediastinal window, we are seeing all these lymph nodes, right paratracheal, aortopulmonary window. There is fullness along in the hila. There is no contrast, so I can't show you contrast study in here, but there is all of these type of lymph nodes, not much of pericardial effusion, and the pulmonary artery is not that dilated. But as we come down, what we are seeing is in the media's upper abdomen also, there are all these small lymph nodes, extensive lymph nodes that we can see in the upper abdomen also. When we look at the lung parenchyma, so in the lung parenchyma, we start to see these small isolated nodules here, fluffyish nodules, semi-solid nodules, and you can see another nodule across here. And here you can see the hila prominence, hila lymph nodes much more obviously than in the mediastinum, and then again patchy inflammatory changes in the lower lobes. Just to impress upon the adenopathy, what we can see are these PET CT images where we are seeing these large volume lymph nodes across in the mediastinum, hilar lymph nodes, some along the internal mammary, also pretty much symmetrical in the hilar. And as we come down, we can see some upper abdominal lymph nodes also. There's no interstitial lung disease as such. Putting all of this together, yes, the differential diagnosis remains sarcoid and lymphoproliferative disease. The fact that the patient has had a heart block and those nodules that we are seeing in the right upper lobe lung, sarcoid is more likely than lymphoma in this case, but there is no interstitial changes in the lung. And I think some of these lymph nodes are very easy to access and excise biopsy.
Yeah, I'll just.
Yes, sir. After this, we had discussion with hematologists also, because the more worried aspect was about lymphoproliferative disorder. They took up and they did bone marrow biopsy, which was seemingly less risky at that point, and then was referred to us after bone marrow was negative for discussion about possibility of EBIS. We said because of this cardiac issue and conduction pacemaker in situ now, we said high risk for an invasive procedure, and we discussed with surgeons also who took out the left supraclavicular lymph node that showed granulomatous lymphadenitis, AB fungal stains negative. Gene expert also we did, that was also negative. And then the patient came to me. I again reconfirmed with a Manto and IGRA I wanted before I started on immunosuppression. So those two things also are negative. So now the question, the patient is very comfortable, no respiratory complaints. Still there is on exertion some kind of palpitation, the ongoing palpitation. So I couldn't do a PFT or 6-minute walk test, which is not very comfortable doing. So I've started on prednisolone 20 mg once daily. I discussed with cardiologist. He said like all the decision is probably he doesn't want to get involved in the management of sarcoidosis. So the question for the panel is: it cardiac sarcoidosis management? Is it Visolone enough? Do we need dual immunosuppression? If Visolone is enough, low dose protocol is what I started. Is it that again enough? Is there a role for cardiac MRI? And about concerns about immunization also the question.
Yes, Professor Wells.
Well, we do discuss patients like this weekly for 2 hours in a cardiac sarcoid multidisciplinary meeting, and I'm going to say that the odds overwhelmingly favor sarcoid. You still got the caveat that a lymphoma can give rise to granulomas in organs not involved by lymphoma, but having said that, there are the nature of the cardiac presentation, the convincing nature of the cervical node histology, you've got to manage aggressively, obviously, as for sarcoid. Then let's go through it. Do you have an SUV max on PET? What level of inflammation are we looking at?
What was SUV?
I cannot tell you on these images. I think they'll have to look at the report.
But if you just look at the images, it's
these are looking at an 8+.
Yeah, right. So it's very hot.
Yeah.
Now, your worry with steroid, you need high-dose steroid quite urgently, but your worry is that suppressing inflammation unevenly across the heart will trigger rhythm disturbance at high doses. So an intracardiac device is a key question here. If you've got a lot of damage, then without a shadow of a doubt, you need an intracardiac device in the long term. And if you think about the presentation, I'll be very surprised if there isn't a lot of scar tissue there, and MRI is the way to see that. PET, if you've done a perfusion measurement, PET's quite good at picking up scar tissue, but most people don't do the perfusion bit of PET. They do the SUV max, but they don't do the perfusion. You want to know about scar burden. Now, the next thing is that you want to switch this off definitively, and the way to minimize steroid with an ICD in place is methylprednisolone with a quick reduction to, say, 15 milligrams daily of prednisolone. You want the patient off steroid as soon as possible. So I would start combined therapy and add methotrexate. And then if that cocktail is failing at 3 to 6 months, you've got to think about anti-TNF therapy at that point. My final comment is the first presentation implied ischemic heart disease with the words that were used. I think I would want to know that the coronaries are okay at the end of all of this, that a CT coronary angiogram has been performed. I might have missed it, but that was the one thing that bothered me when you put up the first slide. There was talk about an infarct. Well, you wouldn't.
Yes, sir.
Yeah, sorry.
Sorry, sir. A repeat angio was done in our hospital, which showed normal coronaries, which sluggish flow.
That's what you need to know. So I can put a line through that comment. We do occasionally get ourselves into trouble that we think we're dealing with cardiac sarcoid. We are actually dealing with ischemic heart disease. But I mean, that wasn't commonsensical. My only worry was whether there might be two things going on. That's all. I think, obviously, the lymph node signal isn't coronary artery disease, for heaven's sake. So I would say get on top of this. I do think often methylpred switches off a process that can't be switched off as well with traditional doses, but then quite low doses will sustain a response, but would never achieve a response. And I've seen this time and again with methylpred in bad cardiac sarcoid. You've got to get the ICD in place, and you really have to know about the scar burden. That's going to be a key consideration in the long term. With risk of sudden death here, I would say, if you've not got ICD protection. And I would be very surprised if the MRI doesn't show major late GAD enhancement indicating scar tissue.
I want to ask one question. You told that after 3 to 6 months, find out whether patient is improving or not. So do you expect the heart condition to improve? Which condition to improve?
Firstly, you're asking whether the treatment is suppressing inflammation. And if it's not suppressing inflammation, out at 3 to 6 months, using both methotrexate and the steroid regimen, the sooner you get an anti-TNF agent aboard, the better. So I would say that the way to a bad outcome is to be too gradual in the way you introduce things in what is severe disease, and to take a year or longer to actually work out that you're not winning. And I think the plus about combination therapy is you can minimize the steroids quite quickly if things are going well. Now, secondly, you will not improve much in the way of scar tissue, except that serial PET has shown that there's perfusion improvement signal, and it's a good trial endpoint. And I think immature fibrosis can remodel. So you may see some improvement in cardiac function, but on the whole, your late GAD signal will be pretty robust. I don't think it will go away. It's almost always scar tissue. People say it can be inflammation or scar tissue, but I think CMR is not so good at picking up inflammation, oddly enough, as PET is. So you need both PET and CMR. Okay. And I would say that you won't remove scar tissue. Now, if there's cardiac dysfunction, you may well with the best pump support, and that's where a cardiologist has to be involved, use of pump support, and you might well see major improvement, but it's not going to be due to the immunosuppression, I think. So Trice thought that cardiac function got better with immunosuppression. We always pile in enthusiastically, hoping that will be the case, but actually, more often I've believed it was the other therapies that you've used to support the heart that are actually causing the improvement. And I think that's pretty much it. You know, you could talk for an hour on a case like this, but those are the crucial bits I would want to pass on.
Okay. Anybody wants to comment? Rajan sir, Prabhu Desai, Murli Mohan sir.
Yeah, I think, immunosuppression is so critical. It's just like that cardiac sarcoid case we discussed a couple of months ago, who's still in with a low ejection fraction. And he was getting worse and worse. And because there was late gadolinium, there wasn't much, I think the impression from, I think Vimal was seeing that case. You recollect, Vimal? And,
Yeah.
and you said that there's not much inflammation. It looks all fibrotic myocardium. And so we decided to drop steroids. He's in another hospital. And he got worse and worse, more and more inotropes. Couldn't even waitlist for transplant because he developed a low-grade fever. And then we suddenly decided that even the transplant unit wasn't going to accept him, and we convinced the cardiologist to give him 500 mg of methylprednisolone. The cardiologist relented, and then he got a little better. Then we gave him 1 gram, and he's got much better. He's off pressors, everything, So this is something we're really learning here. We haven't, as pulmonologists, seen as much cardiac sarcoid as Athol's unit has seen. And I think we're learning all the time in this space.
Yeah, we get 300 referrals plus a year to a cardiac sarcoid service. And we spend 2 hours a week discussing 8 cases every week, sometimes 7, sometimes 8, sometimes only 6. And we get accessed from around the UK. And by the way, Sujit and Asmita have both joined as observers of this process. Now, in your case, and I don't think I was there at that meeting, I don't remember the case, was it what the judgments were made on MRI that there wasn't inflammation?
Yes, it was made on MRI. You weren't there that discussion, I thought.
Would have said is don't believe the MRI, because we now have formal data that is in press demonstrating how often MRI fails to pick up major inflammation that is obvious on PET. So MRI is brilliant at scar tissue.
Right.
Is brilliant at inflammation. PET also gives you inflammation that matters with perfusion, because the inflammation that matters is the inflammation that scars. You're best to use them together in a case like this. And I bet you if you'd had PET in your case, you would have seen ballistic signal from PET. And I've seen that with very little or nothing on a CMR.
Yeah. He wasn't fit for PET. He came into the clinic with a blood pressure of 70.
Yeah.
And it was crazy, really. 10 to 15% ejection fraction.
Yeah, I think that's fascinating, because you might be talking about a very acute stunning of the myocardium in that setting. Now, I've seen that with dramatic presentations. There was somebody who was asleep at home and dropped dead in his sleep, but his wife resuscitated him. He came to us with a background of good health. With that sort of cardiac function out of the blue, it was sarcoid. And actually covered very nicely with immunosuppression, and it sounds like your case might have been something like that.
Absolutely. And it's amazing because he had this low-grade fever, no one was willing to pulse him. The cardiologist, but then the ID specialist and the pulmonologist, he's in another hospital. We were talking to each other and we said, this is his only chance, because the transplant team weren't ready to take him, and they weren't ready to put in an ICD either because of the fever.
Yeah, you've got to put an ICD in these cases. You have to use steroid. You've got to get response. But if you go giving IV steroid in the setting, people will get sustained VT or a VT storm. And that's because immunosuppression suppresses inflammation unequally across a scarred myocardium. So, and even oral steroid at 30 milligrams daily can trigger a VT storm in this sort of setting. So you've got to have an ICD in place.
So you're saying that the moment you have stability, get the ICD in?
Yeah, and we quite often get the ICD in, and now we're safe. And this is not in your extreme example. I mean, you've just got to act there. We get the ICD in, and we will wait for 2 to 4 weeks to give the methylpred, because you're safe with an ICD. And you can die of a ventricular storm, by the way, with an ICD, but it's very, very rare. We had one case like that. And you're worried about infection when you're placing a device if you use methylpred instantly. So you probably have to wait at least a fortnight. And then I would pile in with methylpred plus methotrexate. I wouldn't mess around taking 3 months to get to the methotrexate target dose. You go straight to 15 milligrams a week. If there's nausea, which is the rate-limiting step, you use it subcutaneously. You get combination therapy aboard. You know methotrexate will take 3 months to reach its peak effect. You're bringing the steroid down. We go straight from methylpred to just 15 milligrams daily of prednisolone. We've got great outcomes with serial PET out at 6 to 12 months using this regimen. And then you make a very early judgment about the need for anti-TNF in really nasty cases like this. Some people would introduce anti-TNF at the outset. I don't think you should do that. I think you get a quick enough sense that steroid is winning. And so it seems to me that you can end up giving a drug with side effects you don't need. So I would be holding back on the anti-TNF in a case like this.
I will convey this to the pulmonologist. This was like a masterclass on cardiac sarcoid, the last 4 minutes.
So we've seen exactly the same thing, and we end up having a lot of trouble because our cardiologists say MR is done, so that is good enough. But we say, no, you need to do a PET because MR will show fibrosis and PET. And then the corollary is also true. PET may be normal, but MR will be positive because the fibrosis will be shown. So you need to do both in most of these cases.
Yes, and if you've only got PET, you better do perfusion as well as the inflammatory signal, because perfusion's quite good. I mean, it will match late gadolinium enhancement. And most units either have easy access to PET or easy access to MRI, and we're lucky enough to have both. And it makes the world of difference. Quite often you're not sure about MRI signal, it's subtle. You go to PET and you say, yes, PET in the same regions is telling you that what you're uncertain about on MRI is definitely real.
So should I ask my cardiologist to switch from pacemaker to ICDs?
Yes.
I would just put one thing before Dr. Athol says anything. Get an MRI before you do that. Just to make life easier.
That is a good idea. Look, your worry is about dropping dead, and your worry also about a VT storm. So I think that a pacemaker is not going to be equal to either problem. And especially with the need for high-dose steroid, that is your concern. You've got short-term concerns and long-term concerns here. Now, if you've got a lot of late GAD and an ejection fraction, I would say maybe we're too conservative and it should be less than 45% an ejection fraction if you've got a lot of late GAD. But internationally, the threshold is lower than that. So a lot of late GAD, low ejection fraction, your worry is dropping dead, and in the longer term. And in the shorter term, your worry is a VT storm. And I don't believe in this case that it's likely that you won't have late GAD significantly, but just occasionally, I suppose, with a very short course, this could be surprisingly late GAD free, and it is worth knowing that. So get an MRI, but expect to be replacing a pacemaker with an intracardiac device.
Thank you, sir.
Okay. Thank you, Vijay. Anything more you want to ask, or we'll move on to the last case?
Yes, ma'am. That's all.
Thank you.
Like a masterclass on cardiac sarcoid from Athol.
Yeah.
I tell you, it's a fascinating area. It's like the old days of ILD, multidisciplinary practice in this. If you have a chance to get involved with this, anyone listening, for heaven's sake, it's a fabulous area to be involved in. Anyway, that's enough from me, I think.
Yeah.
Thank you. Sorry, my video is not on because of some hardware issues. This is a 20-year-old female, and she's a CA, absolutely well till 4 months ago when she developed a little right-sided chest pain, a bit breathless, grade 1 MRC. She was tiring on climbing stairs for a while, since about February this year. But no cough, no autoimmune symptoms. Her mother has left upper lobe bronchiectasis with a little fungal infection about 15 years ago, grandmother asthmatic. Normal saturations, pulse rate okay, but she's thin built with a BMI of about 18. She had a high arched palate, and she has bilateral inspiratory squeaks. This was her blood work. As you can see, nothing much on the autoimmune, but you will realize what she probably has in her lungs because we did VEGF-D, myositis blot negative. This was the MUC5B GT genotype, which I don't understand, and thankfully we have Dhanya and Pooja here. Ultrasound abdomen, right ovary, dominant follicle, rest was normal, echo normal. Next slide. This was her lung function. So she's never had a lung function before, and this is the first time in her life she's had one. And this is what she has. And her symptoms are just since 4 months. And Vimal, maybe you'd like to share I think the next slide was, Asmita, you have the next slide?
We'll
Yeah,
see CT.
PT. PT, yeah.
Just 1 second. Okay. So we have 2 CT scans.
That's right.
And so this is the 20-year-old female. This is a CT scan from June of this year. And what we can see is that not much of lymph nodes, pulmonary artery is normal, nothing happening in the axilla. The liver is normal. The kidneys are normal. And I'll just show you the other image first. Yeah, so this was, and when we look at the HRCT scan, so what we are seeing are these large cystic spaces in the lungs bilaterally, extending all the way from the lung apices, and very, very, very tiny nodular changes, subtle, tiny nodular changes, but some of these nodular changes are there in here. And as we go down to the lung bases, there's a lot of coalescing of these nodules together. And what you would have seen also is that there is a small pneumothorax on the right side. So that's a small pneumothorax.
So that explains her right-sided pain that she had. Yeah.
Yeah. So this was the pneumothorax. And in terms of timing-wise, this is another scan which is a month or so ago, and you can see similar changes. She's starting to get some adhesions to the lung, which is preventing this lung from actually collapsing. And again, some nodular changes across here. None of these nodules are getting cavitated or in the transition from a nodule to the cyst, but very irregular shaped cyst putting together. She's a non-smoker, you said, isn't it?
That's right.
Yeah. So cystic lung disease, differential diagnosis, our standard ones that we would think about. I would keep LAMP in the absence or in the presence of immunocompromised. LIP also would be something, or one of the genetic forms of cystic lung disease is what I would be thinking.
So Pooja's lab had done the VEGF-D, the ICMR lab, and that was normal. And then she was seen by me and Zarir. Zarir also asked for genetic testing, because she's very young, 20-year-old. And these were the tests that we got in, and I mean, Pooja told me there was nothing significant there. Anything, Pooja, Dhanya, on these tests?
Hello.
Yeah, Pooja.
Sir, yeah, this med genome report, Dhanya ma'am would be able to explain it much better. But what I saw is, obviously there is no significant, like no significant variant reported. Also, they have mentioned that there is an heterozygous duplication on chromosome 16, but they have mentioned a part of region where that duplication, like the part which is duplicated, and they are not sure exactly which part is duplicated, but they know it that it is on chromosome 16. So also, since it is heterozygous, so that is why they have also recommended parental testing. So maybe so I was just checking, like what other variants are related to ILD present on chromosome 16. I just found out that like FLCN and as well as COL3A1, which is related to vascular Ehlers-Danlos syndrome, and this surfactant metabolism dysfunction related gene, which is ABCA3 gene, that is also present in chromosome 16. So not sure if these genes are like they there is any change in these genes, but they have also recommended parental testing, because without that won't be able to comment on like what part is duplicated. Also, the additional information which they have mentioned regarding this
Yeah.
FAT14 and this GLA.
And two other variants. Yeah.
Yeah. So those as well, they have mentioned as for FAT4, they have mentioned likely compound heterozygous. So that term is usually like it is not sure that both of the variants they have come from mother or father, or one from mother and one from father. So hence parental testing was recommended in the report. That is from my side.
So parental testing we'll get done, but what do we do with the girl? That's my worry.
Yeah, so
Dhanya?
once it is clear, yeah, Dhanya ma'am can continue.
I think Dhanya has left, sir, because she has to like go. So
Okay.
she will
So
get
my
back.
question was, what is I met her last week, and this girl, we haven't commenced anything. We just told her to do physio on supplemental oxygen till we discuss her in MDD. The chest pain is bearable. She's not much now. She's gained 1.8 kilos in the last 2 months since I last saw her. What is our working diagnosis? And I don't think she's fit for a VATS biopsy. So should we do a cryo, or should we do a BAL? She has inspiratory squeaks. And she seemed fine last week. And obviously she's not fine physiologically. So that's all.
Well, I want to think again about the underlying diagnosis. When you've got aggressive cystic disease at this age,
Right.
genetic things, and the other thing is disseminated Langerhans, which might have very atypical appearances in the lungs. And I don't know if you've considered disseminated Langerhans.
No, we never considered it because she wasn't a smoker, but
Oh, no, that's
yeah.
the moment you're talking about that form which is disseminated occurring in childhood,
Yeah.
smoking is no longer relevant. Now, some patients that get it in adulthood, they do smoke, and probably that actually attracts the disseminated involvement to the lungs. What I can't tell you is the true CT range of this form of Langerhans. Now, you wouldn't look at that scanner much like Langerhans for adults that are smokers, but you would still say it could be. But it would be unusual, wouldn't it? Now, the moment you're thinking about childhood Langerhans, disseminated Langerhans, that is involving the lungs, I'm not sure I know remotely enough about the CT look on that, But I would be taking that into account here as the other thing that might emerge in childhood to actually late childhood to present with quite aggressive lung involvement. The sound stopped me hearing properly about the genetics, but I got the message, I think, that you can't tie in cysts to what was appearing on the genetic profile. I didn't know lymphangiectasia as a word, so I do wonder if there might be some strange link to a lamb-like process, but I mean, a lot of these links are not even in the literature, so you're going to be left with a question mark. My first step, I think, would be to screen for systemic Langerhans. I'm not sure how much joy you would get from a biopsy in this case. You're biopsying cysts with precious little else that you can see in the interstitium, suggesting an active process. And if it was dangerous, yeah, sure, I'd consider a cryobiopsy. When you look at these spectacular cysts, I'm a bit nervous about that when you think about the lung function. But between a rock and a hard place, for sure, this is the sort of patient that will move quickly towards transplant.
Prahlad?
I don't know what is her current general condition.
Very good.
And she has a pneumothorax, which is probably improved.
Yeah.
I would like to rather keep her under observation for a few days unless she develops a recurrence of pneumothorax. And then probably take a biopsy and pleurodesis on that side at least.
So you would do a VATS biopsy, Prahlad, not cryo?
VATS biopsy, yes, yes.
Would she be considered fit for VATS biopsy at all in your unit?
We would be uneasy with such severe disease.
Right.
You are thinking about, I mean, the justification might be that you are going to come up with a specific therapy.
Yeah.
The therapies, the two disorders that might give you a specific therapy are Lamb and Langerhans. The other cystic disorders, it's very difficult to buy LIP, isn't it, in the absence of a run-in of major inflammation in the lung parenchyma over a period of time. You'd be saying burnt out LIP here without anything to indicate that you had a long prodrome of LIP. So I'm in two minds about this, I have to say. I'd be worried about a biopsy in this case. Sometimes you have to say, though, that the greater danger is not having the information. I'd just be happier if there was something about the appearance that was more than just straight cystic involvement that I thought would give you an answer. But,
And when you say screen for systemic LCH, what screening would you recommend?
I would do a skeletal survey for a start.
Right.
I'd get involved. I tend to talk to an LCH unit in a case like this. You're thinking about diabetes insipidus. Your skeletal survey will often actually turn up trumps. I don't want to reel off the list of other tests from memory, to be honest.
Sure. I'll check on that. I'll check on that as well. Yeah, but that's important. I think I'll do that. The biopsy, actually, if you see her, Prahlad, you will also think she's fit for a biopsy. She just walks in cheerfully and like, what's all the fuss about? That's her current condition. But it's, looking at her lung function, I am very concerned about doing. I think I'll ask her to see you once and you let me know, Prahlad. What do you think?
I would like to ask Athal and Vimal, childhood children hypersensitive pneumonia, when they get complicated, do they get more of cystic lung or whether they get honeycomb?
I don't think they do. I think we would see more of that surviving to adulthood if that was the case. But obviously, I really should say very little about pediatric ILD. I just think it's a different set of diseases. For example, they have UIP sometimes, which does really well. So I
And
think
and does the Marfan's features or
Yeah,
Ehlers-Danlos syndrome,
he
do
has
they
Marfanoid
manifest such
features.
a huge cystic lung disease like this? A Marfan syndrome or a Ehlers-Danlos syndrome, these two conditions where their cystic lungs are seen. So are there such an extensive cystic lung, or it is some sort of a very mild cystic lung disease?
Look, I wrote a chapter at one stage a few years ago that included Marfan syndrome, and you do look up everything. And one of the great things is the lung complications are so rare and so rarely described. You can read the whole world literature quite easily. And at that stage, I don't remember a case like this. You've made a key point, though. I think this is the moment for midline search, where you put in a number of paired terms and you just see what's been described in isolated cases. It's amazing how often that will throw up a report with a scan that looks like this, for example. I've done that over the years. It's one of the things you have to do with very rare diseases. People send you rare disease because apparently you're a rare disease specialist. What you're a specialist at is going on Medline and putting in paired terms. And someone else this, and look, the scan looks just the same.
Yeah.
So, Dr. Prabhudesai, the Ehlers-Danlos and Marfan's that we have seen, you can have large cysts, but they tend to be much more restricted to the upper, and they are often paraseptal. This is quite centrilobular, and the lower lobe distribution is also very unusual for them.
Regarding
You
this
mentioned
childhood,
nodules, isn't it?
Sorry, Dr. Bulle.
You mentioned nodules in the lung. So that
Yeah.
a little more towards lip and LIP and possibly, other infiltrative diseases, light chain deposition disease and all that. That comes into differential of a cystic disease with nodules. So I'm just wondering if it's just worth doing, as Professor Well said, doing a skeletal survey or a PET, and doing, serum electrophoresis, protein electrophoresis.
Yeah, I will get whatever I can do non-invasively, Murli, for sure. I agree with you.
I mean, the nod could be targeted in a very targeted biopsy. That would be the justification that you can be exact enough about getting a site. I have to say, eyeballing it, probably you needed the eye of a radiologist to be able to focus on the nodular bit. My
So
great
if you,
friend
sorry,
talk about radiologists having the eye of a hawk and the mind of a weasel, which is basically brilliance at picking up on small things like that you might biopsy. So might ask you actually, in your radiologist view of this, did you think there was on the scan a suitable target for a biopsy in the nodular change?
The only challenge is those nodules are deeply hiding behind the cyst.
Right.
So they're very close to that. So not.
You think
really
not?
easy. No.
So you'll have to do a VATS then. That would be much safer than doing a cryobiopsy.
I think you might be right on that, but
yeah.
you better do the non-invasive stuff first. I think Suji hit the nail on the head.
Yeah. So I will tell her about this, and I think what Pooja mentioned about those genetic chromosome 16, which is the problem chromosome here. I think Pooja, we should put this on a Medline search. I agree with that all. We may find something here. Yeah.
okay.
Thank you, Asmita. I think.
I just want to ask Vimal Raj sir. So in our hospital, we see many because we have a very good hematology department, and I have come across many LCH of childhood diseases. But we do PET CT. Maybe we directly go for PET CT because of its availability, or skeletal survey is the better. I don't know.
No, in India, we've actually moved away from skeletal survey.
Yeah.
our radiographers don't know what skeletal survey is.
Yeah.
Even
Yes.
multiple myelomas and everything, if you ask, they'll just say do PET CT. Even
Yeah, that's what we do. Yeah.
I'm sure Bhavin is going to tell me the same thing as well.
I suspect our local LCH people will say exactly the same. As based on the cases today, I think you should rename this not as the ILD multidisciplinary meeting, but as the dramatic disease of the multidisciplinary meeting.
Yeah, we have very cases, and yeah, this was
Thank you,
great.
Asmita.
Thank you. Thank you.
Yeah,
The next meeting will be on 3rd October.
Right.
Hope everybody is available.
What date in October?
3rd October. 3rd.
I'll try and make my flights to Crete outside this time if I can.
Okay.
And
Okay.
for the audience, one slide. Asmita, do you have that to
Yeah,
project?
1 second. I'm so sorry. I forgot. So we have some announcement, and over to you, Bhavin. Sorry, Rajan sir.
So we have our diffuse lung disease update every year, and this year our focus is CTD-ILD. We have Erin Wilfong from Vanderbilt and Sonia Danoff from Johns Hopkins coming. And so it's a half-day meeting on CTD-ILD with two unique workstations, ILD in the laboratory where we are all learning, and a workstation on difficult conversations with two of our outstanding palliative medicine specialists taking that. And the laboratory workstation, we have histopath and histochemistry with IHCs, short 10-minute talks, immunology, serology, and molecular. Pooja and Dhanya are involved in that. 4 cities, and you can scan this QR code that on the slide that Asmita has put up to register for the meeting in whichever city you're in. If you're in any of these cities, if you're not in these cities, try and travel to one of them. It's a short meeting, great faculty, and we thoroughly enjoyed organizing it. I hope you enjoy attending it, any of you all coming.
I'll put it in our groups also, and
Thank you.
thank you so much.
Thank you, Asmita. Thank you.
Thank you.
Thank you.
Thank you,
Thank
Sarda.
you.
I'm sorry there was no slides, but thank
No,
you.
I really enjoyed the discussion too. Really
Thank you.
enjoyed the discussion. Thank you so much.
Being with
Thank
us.
you, Shraddha and
Thank you so much.
Dhanya.
Thank you.
We have that laboratory workstation because of all these people. I mean, they're so well subspecialized, we're able to do these meetings now in India. So I really have to thank Asmita for getting them all on one platform. Thank you.
And maybe next time I should have put Dhanya's case as a first case. I forgot. I'm sorry for that. I know she has to leave by 5:45. Okay.
Sujit, you just
Yeah.
to comment at the end of this briefly, Sujit.
Yes. And we have a webinar tomorrow on antifibrotics and ILD, where Athol, Raja, and Athol, Raja, and Bhavin are there. So tune into that also tomorrow evening, 7 o'clock. Lots happening in the space.
Sure.
Are we offline?
Akshay,
Asmita?
can we make it offline, please? Yeah. Akshay, can